I'm just trying to find out where I can share the screen. Where is my icon to share my screen? That's all.
Share the entire screen, yeah?
Yeah, I'm just trying to find an icon where I can share the screen.
No, just beside the video, down at the course.
Oh, yeah, see it. Oh, thank you. Can you see it? Can you see it now?
No, still?
Share the screen. Can you not see it? No.
Share the whole screen, yeah? The entire screen.
Yeah, I did. Let me do this again, shall we? The entire screen. Yes, choose what you share.
I can show it from my side, the presentation, if you want.
I don't know why it's doing this. There's no firewalls or anything there that could stop me from doing that. Can you see now?
Yeah, perfect. Yeah.
So yeah, I chose one window to share. That's maybe why. All right. Tell me when to start.
Yeah. So I'll just make a brief introduction, and then can you start? So. Just waiting for Professor Ashab to join.
Yeah, of course.
Okay. So good evening, everyone. So we'll start our January monthly journal club under Egyptian Orthopedic Association and OrthoBima. We have two hot topics today. So the theme this evening will be arthroplasty. So we're speaking about management of neck of femur, and Ali will be starting to tell us, shall we do a total hip replacement or hemiarthroplasty of fracture neck of femur? Ali, please.
Good evening, everyone. Thank you for inviting me and allowing me the chance to speak about this topic. I've been asked to present this study about neck of femur, as Mr. Hashim said, and I wish I can tell you an answer. So far, there is no sturdy answer to this question. So the title of this paper is Total Hip Arthroplasty or Hemiarthroplasty for Hip Fractures, and this is an article that has been published in the New England Journal of Medicine in December 2019. So just a quick background. We all know that hip fractures represent a major health burden to all health systems. Across the world, the health system faces a lot of hip fractures every year. It is estimated in the UK alone, there is about 76,000 hip fractures annually, and this is from the National Hip Fracture Database. Is also estimated about 70,000 in England and Wales annually only. Also, we think that above the age of 50, 1 in 3 women and 1 in 5 men will sustain a hip fracture at a given point. And therefore, it is a major issue.
Sorry, Ali, for interruption. You are sharing your screen. You are going through the presentation because it's still on the first page.
Oh, all right. Okay. Yeah. So I moved to the second one. Did not that show?
No, still on the first one.
Okay. Can you see that now? Second one. Or third?
Yeah. You can start just slide show. Yeah. Thank you.
Now, can you see that this slide now? The background slide.
Yeah, I can see it.
Right. Okay. And as any big major issue or major health problem, there will be a lot of guidelines and a lot of recommendations and a lot of policies and stuff. And therefore, in the UK, we have the NICE guidelines. We have recommendations from National Health, from the National Hip Fracture Database. By the way, it's a very informative website. It's a good platform, and it can tell you if you work in the UK. You can, especially if you work in England and Wales, you can log on and have a look at your own trust and see what they are doing in terms of parameters, the goals achieved, and recommendations, and all of that. Sorry, excuse me. And every year they come with some recommendations and a report which details the progress of each trust in England and Wales. So we know from the NICE guidelines now that the main dilemma is the displaced intracapsular neck of femur fractures. So not only the hip fractures, it's a big issue, but also the subset of the displaced intra-articular fractures or intracapsular fractures. Sorry, these are the ones who can represent a challenge when we make decisions. And the NICE guidance in particular in this area, they say that in terms of the surgical procedure that is to be offered, you can offer a replacement arthroplasty in people with displaced intracapsular hip fractures. Then they come to this point where they ask us to consider, so they are not telling us to do so, but they are asking us to consider to give offer a total hip rather than a hemi in patients who, first, able to walk independently outdoors without or with one stick only. And then they added also that they don't have any comorbidities condition preclude that surgery. But recently, in 2023, they've added another line, which I think sheds a light about the ambiguity of this problem or ambiguity of this answer, where they said that also are expected to carry on activities of daily living independently beyond 2 years. So if you think these patients are going to be able to carry on their DLs independently beyond 2 years, then you may offer them total hip replacement. And again, in their guidelines, the NICE says that it is maybe a good point and to be addressed in future research, whether it's cost effective or not to use hip replacements. In particular, if you are going to use hip replacement, we know that many surgeons prefer to use large heads and dual mobility in order to add more stability and reduce the chances of dislocation as we know it. However, some recent studies suggested that functionally there is no difference, statistical difference between using normal small heads and large heads, albeit there is.
Sorry for interruption, Ali, again. I think the screen is still freezing on the first one background. Now in guidelines.
Okay, how about this one?
Guidelines now?
Yeah, guidelines, nice future research needed.
Yeah, Ali, you need to share the whole screen, otherwise it will be the same problem every time. So share the entire screen so you can make it a slideshow, then you can go through it.
So, okay. So I've stopped sharing and then tried to share again, and it wouldn't. So share the entire screen, but it's not letting me share. It's not letting me share. I don't know why.
Share for you.
So okay, I don't know what to do really. Present now and share the entire screen. Okay, and then do that. Maybe do this. I'm sorry about that. I really apologize, but
don't worry.
Share the entire screen.
Okay. If you want, I can share it from my side and just follow your order.
Yeah, that's fine. If you would like to, that's fine. Is that moving there now?
You can see it now? You can see my screen now?
Yeah, I can see your screen now. Yeah.
This is the page you want to present now?
So if you go to 5, please.
Okay.
Then the one afterwards. Thank you.
Next one?
Yeah, next one, please. Thank you.
You can see the screen now?
No. Yeah, it's moved. Idea research.
How about unshare for a minute?
I can see it now.
Just a minute.
Okay, you can start, Ali.
Right, okay. So what I was saying is that it is important now. So the future research of NICE that suggests it is to look into that in specific point. However, there has been in the literature many meta-analyses have been done and systematic reviews recently published to look into that question, and they agree on many things, but there is some bias, or there are some limitations to these studies, mentioning the details of the surgical approaches, prosthetic choices, the surgeon experience, type of the femoral acetabulum fixation. All of these things can cause chaos to the conclusions, and therefore the ideal research. Can you
next one?
Next one, please. Yeah.
Mohammed, just a minute. Don't share your screen. I will share it from my side.
Okay.
You have to share the entire screen, otherwise you will never have a control. I'll share it. Don't worry.
Okay.
This one, Ali?
Next one, please. So this is just an introduction to the importance of this topic, and therefore now we talk about the paper. So the paper is investigated by a group of investigators that call themselves Health. basically health as the North American really fascinated with abbreviations, hip fracture evaluation alternative total hip arthroplasty versus hemiarthroplasty. That's the group of investigators, and basically they are a group of surgeons who look into the alternatives in cases of hip fractures. Next one, please. So the study design is that it is an international multi-center study. It's an RCT, so it's a randomized control study, but expertise based. So that's different to the normal randomized control, and I'll speak about that in a few minutes. It took place in 10 countries across 80 centers, and the recruitment of patients were all across these centers, and they were funded by the Canadian Institute of Health Research and National Institute of Health. Next, please. So their inclusion criteria, or their population, were basically anybody who was above 50 that presented with a low energy, displaced intracapsular neck of femur fracture, and they were planned to have a replacement. So it's not those who fell and they were thinking about fixing it, or minimally displaced and they thought we're going to fix it. Those ones are the ones who were thought to be to receive a replacement, a hip replacement, a sort of a hip replacement, either a hemi or a total. And lastly, that those patients were able to ambulate prior to the injury without significant help of any other person. So they could use a stick before the injury and still qualify and can be recruited to the study. Okay, next one, please. So the procedure is, and the idea is so what they did is they assigned those people, or these patients, to two arms, a total hip replacement or a hemiarthroplasty, and randomized them. Okay, and this randomization took place in the main center in Canada, online, and then they receive the randomization and they go ahead with the procedure according to the randomization. They didn't specify what sort of hip replacement that they would receive or what sort of hemi, so non-cemented, cemented, monoblock, modular. It didn't say anything about that. It just mentions total hip or hemi. A minimization process occurred at the level of the centers, that operating center, so the centers where they're recruiting the patients. And minimization is a process by which, I didn't know that, by the way, before. So it's a process by which you try to balance your or maintain a prognostic balance to your patient groups or treatment groups according to certain covariates or variables. So basically, when you randomize people, you randomize them according to the computer. It randomizes them completely randomly to either arm of the trial. However, there are certain variants like age, pre-fracture living settings, pre-fracture functional status, and their ASA grade that can play a role in your prognostic balance. Meaning that, for instance, if the computer randomizes too many people towards the arm of the total hip replacement who have higher ASA group or higher ASA level, that could potentially have some sort of bias within it. Or many patients who were randomized to the hemiarthroplasty group who were having a very poor pre-fracture functional status. Even though it is randomization, still there is a bit of bias within it. And therefore, the minimization process is a mathematical process by which you try to make sure that there is a trial of making sure that this randomization, though it is randomized, it does not accumulate those confounding factors to one arm more than the other. Hence, you're trying to have this prognostic balance between them. So back to the design again, there was also blinding. So they blinded these studies, this study or this trial. So this blinding did not occur at the level of the surgeons, neither the patients nor the researcher coordinators, but it happened at the level of the final analyst who was analyzing the final data. So basically means that the patients knew what they are going to have or receive, either a total hip or a hemi. The surgeon knew that. The researchers who recruited patients and then came back with the randomization result knew it. But more importantly, the ones who were analyzing the data at the end point did know which this data belonged to a total hip patient or a hemiarthroplasty patient. And lastly, this is as I said, is an expertise-based randomized control study, which recruited 523 patients. So what is the difference between AB RCT and normal RCT? So next slide, please. So basically, the expertise-based RCT is where you set a standard or a threshold for experience or expertise of the performing surgeons who are going to outperform these, either the total hip or the hemiarthroplasty in our case, to a certain standard below which you do not recruit these surgeons. You do not allow surgeons below that level to operate on these people, to operate on these patients recruited to the trial. And this is good in a sense that you don't have the bias that can come due to or occur due to difference in the expertise of the performing surgeons. And that avoids that sort of bias. Also, it has a good ethical value, ethical point in it, because basically you get experienced surgeons who are able to do either procedure in a good way in both sides, and these surgeons have no ethical problem to perform either surgeries when the randomization question comes back to them. So if the patients were randomized to have a hip replacement, this surgeon is able to do the hip replacement as good as he would do the hemiarthroplasty, and therefore they don't have an ethical problem in there. And that also does reduce the bias. However, it has a drawback, as everything in the world. There is also a balance to strike there. So when you get an expertise-based randomized control study or trial, you need to be in a setting where you have more experienced surgeons, and obviously that reduces the centers that you can recruit from. And secondly, you can't generalize the whole the results to the whole general public of surgeons, because someone can argue saying that these experts are giving us these results, but how about the less average surgeon, what they are going to do? So there is a bit of bias there. Next one, please. So and then these patients were seen at week 1, week 10, and 9 months, and intervals until 24 months have passed. And the follow-up is either in person or via telephone. Next one, please. And basically, there are endpoints. So the main endpoints, or what we call the primary outcome measure, is return to theater within 2 years for any unplanned secondary hip procedure. So that was the main, or the primary outcome measure, or the main endpoint. The first primary endpoint is to look at the number of patients who returned back to theater to have a secondary hip operation, which was unplanned within the first 2 years. You can name it. It can be an open or closed reduction, revision, washout, spacer insertion, soft tissue excision of HO, fixation of a fracture, implant adjustment, etc. The secondary outcome measures were the number of deaths, the serious side effects that occurred with each procedure, and the hip-related complications and the functional outcomes. So functional outcomes were assessed by the WOMAC score, the European Quality of Life 5-dimension score, and pain scores by the visual analog scale and time up and go TUG score. Next one, please. So what did they do? They did, to start with, they did a pilot study at 2006, which gave them an idea about the sample size that they should have. They started with a big sample size, but they managed to reduce it. So, and therefore they were the best sample size would be 1,434 patients with 717 patient in each arm. And they used a proportional hazard model to judge or analyze the primary outcome. And they used the Kaplan-Meier curve for the primary endpoint. So for those who do not familiar with the Kaplan-Meier curves, and if you are planning to do the FRCS exam, you should know that by heart. Really, it's really an important question in the exam. It comes in part A and part B. I've had it in part A and part B myself, but it is as some sort of a survival analysis, basically. So you have, it tells you the survivalship of an implant most of the time, or let's say people, in this case, it will be the survivalship of a total hip replacement versus hemiarthroplasty, and how long do they survive within a given period of time, over a period of time, or it could be a life period of time. And this is usually what they use to determine the longevity of an implant when they give it a 10A star or whatever the scale that the score that they give it to the implant. So the Kaplan-Meier curve is basically that studies or shows you the survivalship of an implant over the other, and they use that Kaplan-Meier curve for the first for their primary outcome analysis. Next slide, please. So were the results? So the results basically so they've recruited 1,495 patients to start with, and then this number has reduced to become 441 patients that were included in the final analysis of this study. That was further subdivided into 718 patients who received total hip replacement and 723 patients who have received hemiarthroplasties. The number of patients who were able to survive or live until the final analysis was 1,243 patients. So they've lost 198 patients died during follow-up within the first 2 years, and 85% of those had available data for the primary endpoint analysis, which to reiterate again was the number of patients who returned to theater for an unplanned hip procedure within the first 2 years. Looking at this table there, which includes or shows you their demographics of their patients, quickly, 70% were female and 80% were above the age of 70, and 74% were able to ambulate without any assistive device before the fracture, and 61.4% of their fractures were subcapital neck-of-femur fractures. Just a quick observation that I've observed from their table, not I'm saying it is statistically significant, but just an observation that the number of patients within so all of these patients sustained the neck of femur fracture, yeah, and they have comorbidities, but the most common comorbidity to exist within those patients were high blood pressure and heart disease. So if you look at the lowest bar or the lowest line of their demographics, you'll find that about 400 plus of each arm of these patients had high blood pressure, had and 250, around 250 of each arm, so that means about 500 had heart disease. Then the third common comorbidity was diabetes, and the fourth one was lung disease and osteoporosis. And this is just an observation of mine. It's not something that, you know, statistically, you know, significant. Just an observation. Next slide, please.
Yeah.
Oh yeah, sorry. So
time is very tight. Yeah. So.
Yeah. Okay. So as a also from the results, we know that we have about 7.5% crossed from hemi to total, and about 2.9% crossed from hemi to total hip, but that was not statistically significant. Coming to the results, so the results are or show that 7.9% of the patients who received total hip replacement did come back to theater for a secondary hip operation within 2 years, whilst those who have received hemi, 8.3% of them had to come back to a secondary procedure within 2 years. Okay, next slide, please. And this is the Kaplan-Meier curve. I'm not going to go through it because of the time, but basically what I want to say in this Kaplan-Meier curve of them, that there is a bit of a change. So in the first year, up to the first year, the hemiarthroplasty, I would say, were doing better. So in terms of return to theater, whilst the total hip replacement were doing worse. So they had a higher rate of going back to theater within the first year. But after the first year, there was a flip. So the total hip replacement plateaued, and they maintained a lower incidence of going back to theater following the first year, and the hemiarthroplasty start to creep up and to return to theater after within the second year, after the first year. Next slide, please, if that makes sense. I hope that makes sense. In terms of the secondary outcome measures, as I said, they lost about 198 patients died during the follow-up, but there is no statistical difference between their death rate between total hip or hemiarthroplasty. In terms of the serious adverse events, they were higher in the total hip arthroplasty group. However, that did not represent a statistical significance. Lastly, overall complications were more frequent in the total hip replacement group, with mainly, as we know or expect, the instability or dislocation is the most common problem. 4.7% in the total hip replacement in comparison to 2.4% in the hemiarthroplasty. Next one, please. The function assessment tests and the WOMAC score were consistently higher in the total hip arthroplasty group. So you can argue that the total hip arthroplasty group did better in terms of functions or physical and mental scores, as well as pain scores. But again, that on the statistical significance level was not important. Next. Their results, they compare the results to others. They are slightly different to multiple meta-analyses that showed that the return to theater is lower in the total hip replacement groups. but that could be due to the fact that their study is short study. It is within the first 2 years only. It's not a longer period of time. And that might represent the difference between the meta-analyses of the others and their study. Next, please. What was similar to theirs is if you pull out the data from the Australian Joint Registry, which has about 18,000 femoral hip fractures over a period of 16 years, we know from their data is that after over a 10-year period of time, the revision rates are similar for hemi versus total, right? And also in Scotland, they had a big study, multi-central, suggested that there is no significant difference within the 2 years period of time between total hip replacement and hemiarthroplasty as well. So what are the strengths of their study? Obviously, it is an expertise-based RCT, that there was randomization, it was multicentric, it had a large sample size, and the referees or the judges for the primary endpoints were independent, so they were not involved directly with the trial. The limitations that the blinding, as I've explained before, was not fully, so patients knew, surgeons knew about what they are going to receive, and that can cover some bias within it. They had about 15% loss of follow-up within at the primary endpoint. Also, data of function during the follow-up were incomplete at the first 2 years, and they had also, and lastly, it's a short period of follow-up. Next, please. So, in conclusion, statistically, these findings were not significant enough to draw a conclusion that one is worse than the other, and therefore, independently ambulating patients with displaced neck of femur fractures, the incidence of secondary procedure within the first 2 years does not significantly differ between a hip replacement, a full hip replacement, and a hemiarthroplasty. That's it. Thank you. I hope that I give you a bit of more questions.
It was really great, Ali. Thank you so much.
Welcome.
So any questions, guys, so you can put in the chat and we can answer it. So health trial is very, very common. So all the people who's doing arthroplasty, or even the people who are dealing with neck of femur fracture, this question is a difficult question to answer. The bias will be there all the time because there's a lot of surgeon decision which doesn't follow the evidence. There's a difference between the GRAF guidelines, between the NICE guidelines, and this always is nearly in every trauma MDT and every trauma handover.
Exactly. Yeah. Every trauma meeting in the morning, you'll have this debate.
Practically is unfair for an active, whatever the age, we don't care about the age, but an active person to give them a hemi. So the hemi at the end of the day, it's a valid option, is very more safer than the THR, but still the patient who deserve a good function, it deserves a THR. Regardless all of this. All these trials are still ignoring the cost, which is all the NHS about. But it's a very good, nice lighting of this problem. Very well done, Ali.
Thank you.
Any questions, guys? Okay, great. Mohammed, are you ready? So Mohammed will answer the second question. If we're doing a THR or a hemi, will we cement or go for cementless? Mohammed?
Yes, on the second limb of hemiarthroplasty, not total. Shall I share my screen?
Yes, please. But share the entire screen.
There's no option for sharing a screen, Mohammed.
It's down just beside the video. will be present now. So you see where the video down?
I got you.
Yeah.
Can you see my screen now?
Yeah, just make it slideshow.
What now?
It's coming, don't worry. Yeah, perfect. Go ahead.
Okay. So good evening, everyone. Thank you so much for giving me a chance to present tonight. I am Mohammed Mahmoud, trauma and orthopedic specialty doctor at Work Hospital. Over the next 10 minutes, we'll be presenting a meta-analysis of randomized control trials on the effect of cemented and uncemented hemiarthroplasty in the neck femur fracture in elderly patient. So just to be focusing on the second control trial that Ali mentioned. I will not add much for the background. I think for all those colleagues who work in UK, we know that the neck femur fracture is almost the commonest injury that we see every day. Rough estimation in the UK, there's about 70 hip fracture per year, which cost over £2 billion. And I think this is the same situation in Europe and even in USA. With aging, with more osteoporosis, we see more patients with neck femur fracture. Hemiarthroplasty, as Ali mentioned, is one of the standard treatment for elderly patient. Of course, if you are saying total hip arthroplasty will be the other upper intercapsular neck femur fracture. And this is the main intention from this meta-analysis, is to find and to assess the effect of using cement or uncemented type of fixation for the hemiarthroplasty, just focusing on this elderly patient with neck femur. And by focusing on mortality rate at 1 year, and to assess the other possible complication, which could be like intraoperative fracture or even postoperative fracture and other complication like infection and the systemic complication that we will go through. For the methodology, it's a meta-analysis of well-designed randomized control trials to ensure high-quality evidence. And they have followed the PERSEMA 2020 statement, which is the preferred reporting item for systematic review and meta-analysis. For the software, during their analysis, they have used Riveman 5.4 and trial sequential analysis 0.9. For the selection criteria or BICO, again, it's randomized control trials, population, or even fracture underwent of hemiarthroplasty. So the main intervention is you cemented uncemented and for the second ones was the other complication like fracture, infection, or systemic problems. They looked at the database mainly through the midline MBase Cochrane Central Registry and the clinicaltrial.gov and the ISR CTN registry, as well the literature. They looked for all the randomized control trial over 5 decades, so from 1996 to 2023, and there was no language restriction, just to make sure that there's a global presentation. Initially, they have identified over 600 study and trial, which ended by just 13 randomized control trial included in the meta-analysis and included over 3,000 patients. The main reasons for exclusion was whether it's duplication studies or it does not meet the inclusion criteria, or even the follow-up of the study available. This is just enumeration of the name of the studies, including the number of the patient in the cemented and uncemented and the year. As we can see, most studies from the UK and from Europe, and one study from USA as well. For the primary outcomes, the assess of the mortality rate at 1 year for the cemented group, those 244 deaths per 1,000 patient, and was quite the uncemented, so it's up to 81 per 1,000. So the risk ratio here 0.87 and 95 confidence from 0.77 to 0.97. So the overall effect, as here from the first plot, the diamond shape on the cemented group favoring cemented to decrease the mortality rate, and the p-value was less than 0.05, so those clinical statistical significance. For the secondary outcomes, again, then we're using the cemented hemi should decrease in the risk of intraoperative and post fracture and implant loosening later on. But it didn't show any significant difference in the other complication like infection, whether deep or superficial, dislocation, or other issues like chest infection, blood clotting, or even duration of hospital operation. During the analysis, they have divided the main patients to subgroups according to the age, according to the sample size and the publication rate, and even they have excluded the trials with very small number of patients and the other with very large number of patients, and this has not changed the outcomes from the meta-analysis. So quickly going through the strength of the study, it's show comprehensive analysis, so it's highest level of evidence. I mean, it's meta-analysis of well-designed control trial, and they have for the grade or grading of recommendation, assessment, development, and evaluation, just to generate the absolute and ratio of the outcomes. During the analysis, they have used the trial sequential analysis, which was performed to exclude the type 1 errors and to add more accuracy for the outcomes of the meta-analysis. There was some limitation, so they did not account the improvement in the cementing technique. As I mentioned, the study included 5 decades, and of course there's a lot of change in the cementing during these 5 decades. This study is just applied for the neck of femur fracture in elderly patient, and the average age was around 80, so it's not applicable for younger patient, and of course applicable for the elective patients. They did not account the application bias, because by the end of the inclusion criteria, they have included only 13 randomized controlled trial. So it was quite difficult to assess for the application bias as well. So for the discussion, cement fixation proved that it has reduced the mortality rate at 1 year, and it has reduced some implant-related complication. It showed favorable results in terms of for the infection and for the other systemic complication. And actually, it is recommended for using cement type of fixation in hemiarthroplasty in elderly patient with neck of femur fracture, and it reduces the risk of intraoperative and postoperative fracture, as I mentioned. So take-home message from this meta-analysis: cemented hip hemiarthroplasty reduce the mortality rate at 1 year and reduce some other complication, and it has added another support to use the cemented arthroplasty in comparison with the uncemented arthroplasty. I hope this was quick and clear. Some evidence.
Perfect, Mohammed. Thank you so much.
Answer any questions if there's any.
Yeah, very nice and informative. Guys, keep all your questions in the chat so we can answer it. So Ahmed is asking any comment on cementation syndrome, implantation syndrome.
No, they didn't specify any cement-related complication in their trial. They did not comment on that at all.
Yeah, and this is a part of the weaknesses. So they look into the good side only. So the bad side is the implantation syndrome, and with it's a balance between because with such an elderly patients, yeah, the bone quality is not that good, so risk of fracture is there. But on the other side, they are frail patient, very high ACA, so they are at higher risk of getting implantation syndrome while you're cementing. This doesn't say that the cement is not. Cement is still the gold standard. So for above 65, still cementing is the best option. Avoiding any intraoperative fractures and good functions. Any other questions, guys? So the NICE guidelines support that. So the study just enforced the NICE guidelines, which supports cemented over uncemented hemi. And this does make sense because, cementing, gets you away from intraoperative fractures and give you more good results. Patient is walking day one. You don't depend on the bone quality by any mean. Even if the patient has any problem, still cementing can solve this for you. And it gives you the option to use different sizes of the stem, especially for the slim patient, the slim small patient. If you opt to use a uncemented, you will end by using a small size, which the evidence shows that has a higher risk of loosening. So, but with cemented, if you even need to use a 35.5, you're still safe to do. So I think practically the paper is very good in forcing a really good idea. So, and I think all over the UK, this is the normal practice. So the normal practice, all are doing cemented hemis. So any comment, guys, even if no question, if anyone have any experience, something to add to this?
Can I just say that adding to your first point, Mohammed, is when you mentioned the cost effectiveness as well, I think non-cemented implants, hemiarthroplasty, would be more costly to these cases as well. And not to forget that these patients have sustained low energy fractures, and that is due to poor bone quality. So you're trying to rely on this poor bone quality to get osseointegration and osteo and bone growth. And again, that defies the logic to my humble opinion. But again, as we say, that is this is why there is research. The research helps help us to sometimes answer some questions, or even ask more questions. But at least it sheds more light on things. Thank you.
Yeah, regarding the cost of I came across a recent evidence that the cost is nearly I've asked myself before the Stryker people, and the cost is nearly comparable, because using 2 mixes of cement and the time you're wasting, because in Belfast they operate the last PHS in Belfast they operate 6 joints a day. The difference between cemented and uncemented in the operative time for them is about 9 minutes. So 9 minutes for 6 cases. So you speak of nearly an hour of theater time. Added to the cost of 2 mix of cement, this makes nearly the cemented comparable to uncemented in the price. So I don't think the cost is the main point. But is to give such a frail patient a safe and an operation with less complication is the main point, especially for these patients, especially the high risk patient. Intraoperative fracture is a determinant problem. So I think I've operated a 99 years old last week. So for this lady, having an intraoperative fracture means she will die. So I think cemented is a safe option. But the cost point, as I explained, I think is nearly comparable.
Yeah, but you can argue also that this hour is going to be spent anyway with the current NHS slackness.
No, that's why Belfast is an example, because they pay it by case.
Yeah.
So that's why they do
Right,
six
okay.
joints a day.
Yeah.
So it makes a lot of difference for them. An hour means another case.
Yeah, that's
and all
not
the
where I
interesting
work.
is the whole team
But it
is
is a
paid by case. Yeah, so surgeon, anesthetist, staff, all of them are paid by case. So every minute makes a difference for them. But if you come to the conclusion, I think the cost point is nearly comparable in both cemented and uncemented.
Yeah, agreed.
I think, Muhammad, if you didn't count that the patient who's having uncemented with higher risk of intraoperative fracture or even postoperative fracture, they will come back to theater and will have another operation, which should add more cost as well.
Yeah. Muhammad is asking a question regarding the outcome. Is the difference between hemi, bipolar, and Thompson? I don't think Muhammad had the study went through the types of hemi.
No,
I don't think so. Yeah,
not really. They had like very specific outcomes. Prime outcomes was mortality rate at 1 year, and second outcomes fracture, intraoperative or postoperative infection. But they didn't like focus in a lot of points, as you are saying. The cement generation has been used. Which generation? What type of implant? No, they didn't go through all of that.
yeah. But I think, guys, so from the point they are looking into, so the looking of intraoperative fracture and postoperative complication, and my belief in 2024, all of them, this is some areas are still operating in Thompson, and I understand that, and osteomore, but I think most of them are doing either bipolar or extra unipolar. So and I don't think this is the point they were looking into. They were looking into the complication, especially the intraoperative fractures and the complication post-operative. So and I think this is the same where the NICE looked in. So a lot of evidence in this point, but I don't think there is a lot of debate in there. All the people agrees that cemented is a safe and effective option. Okay, guys, if there's no more question, we should come to a conclusion. So thank you so much for attending, and we promise you of every time of a hot topic to discuss. So Muhammad should be preparing for us another hot topic next month. So what do we have next month, Muhammad?
It will be upper limb. So will be Rami and me will presenting the next webinar.
Perfect. Okay, so next Friday of February, we'll be discussing upper limb, two novel papers, very well-structured evidence, and you will get something from it. I hope today was fruitful for you and you get something from the two papers. Much for our presenters, for Ali and Muhammad. Very well done, and wish you all a good evening and see you next month.
Thank you, everybody.
Thank you, everybody.